สวัสดีครับอันนี้เรามีกันกี่คนนะครับ
มี19 คนค่ะอาจารย์
19 ใช่ไหมโอเคครับงั้นเดี๋ยวรอให้ครบOkay, everyone see the slides or not?
เห็นค่ะ
โอเคครับครบแล้วหรือเปล่าครับ
อาจารย์ครับ
ครับผม
Can you upload the handout in the chat box?
Okay, I will send it to you.
Thank you ครับ
Everyone is here, right? ผมขออีเมลใครสักคนดีกว่าเดี๋ยวผมส่งให้ในอีเมล
อาจารย์ส่งเข้าอีเมลหนูก็ได้ค่ะ หนูส่งไปให้แล้วค่ะ
โอเคครับแป๊บนึงนะพอดีแชทบ็อกซ์ผมมันไม่ขึ้นนะ แป๊บนึงนะไม่ขึ้นเมื่อกี้ใครส่งเมลมาส่งชื่อเมลมานะครับ
หนูค่ะ
โอเคเดี๋ยวพี่กดพอดีมันไม่ส่งมาอีกทีได้ไหมเอ่ยมันไม่ขึ้น
หนูส่งไปข้อความส่วนตัวอาจารย์นะคะ
ใช่ครับ สรุปเดี๋ยวพี่ส่งสไลด์ให้ไปในแชทแล้วน้องเอาไป distribute ให้เพื่อนก็แล้วกันนะ
ค่ะ
ส่งไปละอันนี้สไลด์แรก Okay, then let's start with the first session. I'm going to switch the second session about cardiac implantable electronic device to the to this morning sessions, because I think that we have to know what it is before we dig deep into the details of other topics. My name is Niti Dohovanit. I'm a cardiac electrophysiologist from Washira Hospital. So we are going to start now. Okay. Does anyone know what is CIED or cardiac implantable device? Do you have any basic knowledge do you know what it is and what we invented for and what type of patients we going to implant this device to? You can talk to me during the session, and if you have any questions, please feel free to ask. Anyone want to answer it?
Is that pacemaker?
Yes, the pacemaker is one of the kind of this device. So in this session, I will describe you the brief history of the pacemaker. And what you need to know from this session is there are many types of cardiac implantable device other than pacemaker. So you have to know all of it. And the indications of the CIED is different between the types of the device. And the last thing you need to know is the basic system of the device, including the pulse generator. The pulse generator is the machine, the small machine that you put in the patient, and it will generate the impulse. And also the leads, which is the connector between the device and patient's heart. Let's start with the brief history of pacemaker. It was first implanted in the year 1958 in Sweden. The patient named Arne Larsson is the first patient who has been implanted. The first device was it's the company that invented the device. That company doesn't exist now, but it's a part of the company named St. Jude Medical, which is one of the company invented device now today. Mr. Larson, he lived for a long time after the pacemaker implantation. The indication that he has been implanted is the heart block. He presented with syncope. So he lived through the years with the pacemaker, and he has been received and renewed implanted for 22 pacemakers until the age of 86 years. He even lived longer than the doctor who has implanted the pacemaker for him. So this is the proof that pacemaker is an essential device to help patients with bradycardia. So there are three types of cardiac implantable electronic device. not just a pacemaker. The first one on the left is what we call it ครับผม
Sorry for extremely interrupting in the middle.
Okay.
As one of my friends said that she hasn't received the handout. Can you check your email once again?
She hasn't received some. I can't.
The
ยัง
handout.
ไม่รับเลยค่ะอาจารย์
ไม่ได้รับอะไรนะครับ
หมายถึงแฮนด์เอาท์อะค่ะ อาจาร
เอา
ย์หนูยังไม่ได้เมล
เอาพี่ส่งไปเดี๋ยวนะพี่ส่งไปให้ในแชทน้องได้ไหมเอ่ย
แชท
สรุป
หมายถึง
แชทส่วนตัว
อ๋อในแชทส่วนตัวใช่ไหมคะ
ลองกดดู
ก็
ได้ไหม
เป็นยังไงคะ
พี่
อาจารย์แชทส่วนตัวไม่มีเลยค่ะ หนู
เอาเหรอ
แค่ส่งชื่อเมลไปกับ
พี่ไม่เห็น
ใช่
เมล
ค่ะ
พี่ไม่เห็นเมลน้องเหมือนกันนะเดี๋ยวนะงั้นเอาจดได้ไหมงั้นเอาอีเมล บอกมาเดี๋ยวส่งไปในนี้เมลน้อง
ได้
เมลอะไร
ค่ะอาจารย์
มันไม่เห็นเหมือนกัน
NURUL ค่ะ ตัวเล็กนะคะ
ครับ
underscore YYY ค่ะ
ครับ
@hotmail.com ค่ะ
ส่งไปแล้วนะ ได้ไหม
ยังไม่ได้ค่ะแป๊บนึงนะคะ หนูกำลัง refresh ยังไม่มีเลยค่ะอาจารย์
NURUL underscore YYY
ใช่ค่ะ
@hotmail เดี๋ยวรอแป๊บนึง
อ๋อ อาจารย์ส่งมาแล้วค่ะ
โอเคครับ
เรียบร้อยค่ะอาจารย์
ครับ
ขอบคุณค่ะ
งั้นกระจายให้เพื่อนครับ
ได้ค่ะ
Okay, so let's continue. There are three types of cardiac implantable device. The first one is we are familiar with. It's called permanent pacemaker. The second one is the automatic intracardiac defibrillator. This one we use to treat the patient with tachyarrhythmia, such as the VT, ventricular tachycardia, and the VF, ventricular fibrillation. This device would give the therapy by shocking the patients and eliminate the VT or VF for the patient to return to normal sinus rhythm and prevent the sudden cardiac arrest. And the third one, it's the cardiac resynchronization therapy, or the CRT. This one will help the patients with low LV ventricular ejection fraction to help reduce the heart failure and reduce the symptoms of dyspnea and also decrease the mortality of patients with low ejection fraction. You need to know that all of these devices has a pacemaker functions. The ICD also has the pacemaker function as a baseline, and we put the function of defibrillator. We add the function of defibrillator into the ICD. So if the patient's implanted with ICD and he has bradycardia, this device could generate the impulse and pace like the permanent pacemaker. And also the CRT has those functions, but there's some difference between the CRT and the conventional permanent pacemaker. I will talk to you later in this session. This is the chest X-ray of the three types of device. Anyone can answer me which X-ray is which device? Has anyone seen the chest X-rays of the patients who has been implanted with the device before?
Can I guess ค่ะอาจารย์
Yes, you can guess.
The left one นะคะเป็น permanent pacemaker ป่ะคะ
Yes, the left one is permanent pacemaker. And which one is the ICD? Oh no, okay, which one is the CRT?
Is it the
For
middle
the
one?
Sorry? Can you answer again?
Is it the middle one?
No, the middle one is the ICD, and the third one, the right one, is the CRT. You can differentiate it from the chest X-ray. The CRT has 3 leads. You see that there's an RA lead, an RV leads, and there's a small leads attached to the left ventricle. This is the CRT. CRT has 3 leads, so it could resynchronize both right ventricle and left ventricle. It will pace at the same time to help the heart pump. So if you see the chest X-ray with 3 leads, you can answer it is a CRT. And the middle one is the ICD, because you can see that there is a coin, the white coin, which the yellow arrow is pointing to. This coin is the defibrillator coin, which we use to give the therapy to the patient. And if you compare it to the pacemaker, there is no coin, there's no defibrillator. The pacemaker lead can only pace, so you can use this to differentiate the type. And the third picture, the picture of CRT, you can see that there is also a defibrillator coin in the CRT, because you can put the defibrillator function into the patient with CRT, and you call it the CRT D. D is from defibrillation. If you don't put the defibrillator in the CRT, we could call it the CRTP or the CRT pacemaker. We can choose this between the type of patient. So the first thing I'm going to explain to you why we need the CRT. There's a theory that if the patient has a very low left ventricular systolic function, or the low LVEF, the right and left ventricle would not pump at the same time. It would cause what we call an LV dysynchronous. The dysynchronous mean that there is no synchrony. There is no the left and right ventricle is not function properly together. So if the left and right ventricle is not pumping at the same time, the patient would experience a reduce of cardiac output, because if the right ventricle pump and the left is not pumping, the interventricular septum would shift to the left, and that would cause the volume of the left chamber reduce, and the cardiac output would not achieve the goal of what patient needs. So we put the leads in the RV and LV, and we try to give the electrical pacing at the same time. So the left and right ventricle would pump in a proper fashion. And like I have explained before, there are two types of CRT. The CRT that we put the defibrillator in, and the CRT that we only put the pacemaker in, the CRT-P and the CRT-D. You can see that in this picture, there's 3 leads, and the LV leads were introduced via the venous system across the coronary sinus vein into the epicardium of the left ventricle. And the RA leads and RV leads were put in the venous system in the endocardium of right atrium and right ventricle. So that nowadays there are 4 brands, 4 companies that are selling the pacemaker and the device, or the device in Thailand. There are Medtronic, the Senchut or Abbott, Biotronic, and Boston Scientific. All of these companies has the basic function. They has the same basic function of all the device, but there are some slightly different between the company in some special function. So if you put any of the company, any device from any company in the patients, surely they can survive. We can give them a proper therapy, but they're they have some special function, like when you buy a mobile phone, and there's some special function that some patient may need one and some patient might not need. If you graduate and you go out in the real clinical setting, and you will see that some hospital will only put one company in the patient, and another hospital only put another company in the patient. So there's not much difference between these 4 companies. The first device I'm going to talk today is the permanent pacemaker. There are 2 types of permanent pacemaker. The first one is the single chamber pacemaker. This single chamber pacemaker means that you only put one lead into one chamber. It could be the right ventricle or the right atrium. The second one is the dual chamber pacemaker. The dual chamber pacemaker, you put 2 leads in the patient in the right atrium and right ventricle. These leads can cooperate while they function. They can track each other. So the dual chamber pacemaker would offer you more physiologic pacing. You can pace the right atrium, and after that, you can also pace the right ventricle in a sequential way. So this would give a patient more physiologic, more natural pacing or the electrical conduction. And the third one is the CRTP. This somebody included in the type of permanent pacemaker, and in some textbook they just separate it into the type of CRT. And there are novel types of permanent pacemaker. We call it leadless pacemaker. It's only invented for 5 or 7 years. It's a small pacemaker which they don't have any leads, and the pulse generator is in the small pacemaker here, and you implant it into the RV via the catheter. This one has an advantage to the conventional device because they don't have leads, and if the patient don't have the venous access, this one we could implant it via the femoral vein and leave it in the right ventricle. And another advantage over the conventional device is that if there is no lead, the risk of infection or the infective of the leads is lower than the conventional type pacemaker. You might see it in the future more and more. And another novel type of device, this one is the ICD. It's called subcutaneous ICD. This ICD, we don't have to deal with any intravenous part. We just put it in the subcutaneous of the patient. But the thing you need to know that this ICD doesn't have pacemaker function. This is the only CIED that don't have the pacemaker function. It could only shock the patient with the defibrillator. So I'm going to talk about the indications of pacing in the patients with bradycardia. The first indication is the sinus node dysfunction, and the second one is the atrioventricular node dysfunction. The SA node dysfunction, this is the anatomy of the SA node. The SA node is the structure around the right atrium and the superior vena cava junction. It would generate the impulse through the atrium down into the AV node to the bundle of his and down to the left bundle and right bundle of your heart. And the ECG that you could see, that the normal ECG, that the P wave was generated from the SA node through the atrium, and when the impulse reached the AV node and the ventricular, it would generate the QRS complex and T wave. So if there is something abnormal in the SA node, there would be no P wave like the flat line here. We can call this the sinus pause. If there is some abnormal in the AV node, there would be no P wave on the ECG. So when will we put the pacemaker in the patient with SA node disease? Surely we didn't. We don't put the pacemaker in all patients with the sinus node disease. Some patients may experience only abnormal ECG, but they don't have symptoms, and we have to choose which patient is proper for the permanent pacemaker, because if we put one of the device in the patient needs a long-term care with the pacemaker, and there are also complications after the implantations. So we need to clear the indication before we implant it in those patients. The first indication is that the patients have symptoms directly attributed to the sinus node disease. For example, the patient experienced syncope after the pause of the ECG, or the patient experienced some dyspnea or the shortness of breath after the long pause of the ECG. So this is another indication is that when the patient has the SA node disease, the patient might not able to increase the heart rate properly after the exercise. If the patient cannot do that and he experience some shortness of breath after he go to exercise, or after the patient work, we would put the pacemaker into these patients. The second indication is that the patient experienced the tachybrady syndrome. The tachybrady syndrome is one of the sinus node disease manifestations. This is, I will explain it to you. It's when the patient is rest, his heart rate may be as low as 40 or 30 beats per minute. But for sometimes he experienced a tachycardia, which might be the atrial fibrillation or the atrial tachycardia. And if the patient has both tachycardia and bradycardia, we have to eliminate the tachycardia, and we also have to increase the patient heart rate. This would be very difficult to give any medications. If you give the medications that would suppress his heart, yes, you could suppress the tachycardia, but the bradycardia would be worse. So we have to put the pacemaker into this patient to drive the heart rate up. And if he experienced the tachycardia, we could give him the medication to suppress the tachycardia. And the third indication is the symptomatic chronotopic incompetence. This one I described before. It's when the patient could not drive his heart rate up while he has some activities. And for the individual who have sinus node disease and doesn't have any symptoms, we don't usually put the pacemaker in. You can see if you go out in the clinic and you see the patient with a heart rate of 40 or 50 beats per minute and he doesn't have any symptoms. The example of this patient is the athlete's patient who have trained so hard and his heart rate was low, maybe 40 beats per minute. You don't put the pacemaker into those patients. So this is the diagram from the American College Guideline with the indication of putting the pacemaker in the patients. For the type of pacemaker, for choosing the type of pacemaker to put in the patients, the dual chamber pacemaker would be the first choice to put in the patient because it gives more physiologic way of pacing. And if the patient could not put in the dual pacemaker type, we would consider the single pacemaker type later. But I want you to remember that the first choice is the dual chamber pacemaker. So the second indication that I would like to talk about is the AV node dysfunction. The AV node is along the conducting pathway of the heart that I have spoken before. It's come after the signal from the SA node through the atrium and through the AV node before the signal went through the ventricle. So the problem with the AV node occurs after the P wave and before the QRS. You can see that this is the complete AV block ECG. You see the dissociation between the P wave and the QRS. This means that the atrium and ventricle is not connected, is not electrical connected. So the atrium is pumping and the ventricle is pumping not synchronized, not in the sequence way. This is called the AV dissociation. It's one type of the AV node dysfunction. It's the worst type. So the indication for the AV block patients depends on the degree, the severity of the AV block. In the patient with acquired second degree morbid type 2, the high grade AV block or the third degree AV block, we put these patients to implant the pacemaker regardless of the symptoms. Even if they are symptomatic, but if the severity of the ECG is morbid type 2, high grade AV block or complete AV block, these patients are going right away to be implanted pacemaker. And the second indication is the patient with permanent atrial fibrillation with symptomatic bradycardia. And the third indication is the first degree AV block and the second degree AV block morbid 1, but only with symptoms. Oh, okay. I have to ask you first that any one of you has the basic knowledge of ECG before?
Yes,ค่ะ.
Everyone know what is the first degree AV block or the second degree morbid 1? Is that correct?
Yes.
Okay, so so in the patient with first degree AV block and the morbid 1, we only put the pacemaker in the patient with symptoms. If the patient doesn't have any symptoms, we usually not implanted the pacemaker. We would just observe the patients and follow up. And for the symptomatic patient with first degree AV block, second degree morbid 1, with this is I think it should be asymptomatic. The slide is wrong. Asymptomatic. Okay. Sorry. This one, it should be asymptomatic patient, like I have said before. That if the first degree AV block are the morbid 1 in asymptomatic patients, we shouldn't put the pacemaker in. So these are all the indications with the SA node and AV node. And also in the AV block, the first type of pacemaker that we should put it in is the dual chamber pacemaker. So we came to the second device, the automatic intracardiac defibrillator, or AICD.
Sunshine, excuse me. I
Okay.
don't think your slide is moving.
Oh, my slide's not moving. Sorry. Okay. Is it moving now?
It's moving แล้วค่ะ
Okay. So the first choice of permanent pacemaker in the AV block is also the dual chamber pacemaker. Okay. The second type of device I'm going to talk to you today, this is the automatic intracardiac defibrillator, or the AICD. In some country like in the USA, they only call it the ICD. So don't be confused with these terms. There are two types of the AICD. Also, there are single chamber AICD, and there are also dual chamber AICD and the CRTD. The difference is that the dual chamber AICD only have the defibrillator in the RV leads. The RA lead is the same as the pacing lead. And I want you to remember again that this AICD also have a pacing also have a pacing function. It could be a pacemaker without the defibrillator coin. Usually we put the single chamber ICD in the patient, but when the patient has some type of bradycardia, such as if the patient has sinus node disease and also have a problem with the VT or VF, we have to put the dual chamber ICD in to help pacing the AV node, help pacing the SA node, and also we need the defibrillator to give the therapy while patient have the VT or the VF. There are two indications for the implantable ICD. The first one is secondary prevention, and the second one is primary prevention. The secondary prevention is when the patient have experienced the ventricular tachycardia or the ventricular fibrillation before, and we put this device in to prevent another event of this tachycardia. And the primary prevention is that the patient has not experienced any ventricular tachycardia or the VF before, but we predict that this patient has a high chance of experiencing those malignant arrhythmia. So we put the device in before they have those symptoms. Another indications in the secondary prevention is that the patients who have survived the sudden cardiac arrest usually arrest with the VT or VF with an uncorrected cause. If there is a corrected cause, such as the patient has the VT or VF because of the hyperkalemia or the hypokalemia, we don't usually put the device in, because if we correct the cause, the patient won't experience the arrhythmic again. So usually the VT or VF, the ventricular tachycardia, has the origin of the ventricle. Both right and left ventricle could originate the VT. So we put the defibrillator in the RV so that the axis of the shock would be nearest to the origin, and this would give you more chance to the success of the therapy. This is the ECG of the VT. You can see that there's a Y complex, which is the ventricular electrical origin of the QRS. And also the ventricular fibrillation is also generated from the ventricle, but there are many points of origin, and the rate of the ventricular fibrillation is very, very fast. So you can see that the ECG is very, very erratic. It comes from a lot of origin, and it's very and it's very, very fast, and faster than the VT. Patients who has the VF always don't have the impulse of the cardiac and always in the cardiac arrest state. So we recommend the secondary prevention indication in the patient who have experienced the ventricular arrhythmia or VT and VF, and the patient who have experienced the cardiac arrest without correctable cause. This is the strongest indication we recommend for patients to be implanted with the defibrillator. And for the primary prevention, which patient we should put the ICD in? There are many researchers and studies that have give us the information that the patient with symptomatic heart failure and LVEF lower than 35% have a high chance of experience a sudden cardiac arrest. So we implanted this device into this group of patients, but only after we have treated them properly with the medications for more than 3 months, and we follow up, and if the LV ejection fraction is not improving more than 35%, we usually put the ICD in these patients. And you can see the sentence that we in the guidelines say that the patient should have longer survival than 1 year with good function status, because the ICD only prevent the patient not to be in the cardiac arrest state. The ICD does not improve any quality of life in patients. So if the patients have a short span of life, such as patient with cancer, if he has only 1 or 2 months left and he also experienced the VT or VF, we don't usually put the ICD in this type of patients because it would only prolong the death. It does not help with the quality of life. So if you want to implant this type of device, you have to consider other aspects of the patients, not only from the cardiac aspect. The patients with a low ejection fraction has 2 types. The first one is Ischemic Cardiomyopathy, or the patients who have the myocardial infarction or the coronary ischemia before, and they have a low EF because of the coronary artery, and even you have correct the coronary artery, the EF has not come up over the 35%. This would be the strongest indications to put the ICD in to prevent the further arrhythmic event. And the second one that they recommend is the patient with dilated cardiomyopathy. This type of cardiomyopathy is the cardiomyopathy that caused from other than the coronary artery, the indication was less strong. Is the indication is 1B, but for the ischemic cardiomyopathy it's 1 and level A. This one is stronger. And this is the recommendation for cardiac resynchronization therapy in patients with heart failure. For the cardiac resynchronization therapy that I have talked to you before, we usually put it into the heart failure patient and to help the left ventricle and right ventricle to pump properly together. So the indication would be symptomatic patient with heart failure and low ejection fraction less or equal than 35%. And we also need other indication other than the LVEF. We need the evidence that the left and right ventricle is not contracted at the same time. So the best indication in this case is the QRS duration. If the QRS duration is longer than 150 milliseconds, this is the strong indicator that tells you that the left and right ventricle is not pumping together properly. So the patient needs a wide QRS complex to be put into the ICD in, and would help with the symptoms and would help with the EF. And another indications for the CRT is that the patient have the left bundle branch block QRS morphology. This would give the best outcome if you put the CRT in. If the patient was non-left bundle branch block, but the QRS duration was very wide, you can also implant the CRT, but the result might not be as good as the left bundle branch block. And for the patient with narrower QRS complex, but not normal, the QRS duration between 130 and 149, we can also implant the CRT in this patient. And also, if the patient has the left bundle branch block morphology, this would give you a better result than the non-left bundle branch block. And another indication is that patient with AF and QRS, the wide QRS duration, we can also put the CRT in, but the result is not as good as the patient with the sinus rhythm. And for the contraindication, if the patient has a normal QRS duration or less than 130, this would not help the patient, because if the narrower the QRS, this means that the left and right ventricle are pumping together at the same time. You put the CRT in, this would not help anything. This would not change the timing of the pumping of the heart. So this is the example of the ECG with the best indication to put the CRT in. Is this sinus rhythm with Y complex tachycardia? The QRS duration is around 140 to 450 with left bundle branch block pattern. So we would put the CRT in these patients, and it would yield a good result. Another one is this one is the YQRS complex with right bundle branch block or non-left bundle branch block. You can also implant the CRT in this patient if the YQRS complex is more than the 150, but this would not yield a good result as the left bundle branch block. So there are clinical characteristics which would tells you that some patients would have a good result after you implant the CRT, and some patients might not have a good result. This comes from the study from the European Society. The patient with the highest response to the CRT is the patient who have a wider QRS. The left frontal branch block are the female patients and non-ischemic cardiomyopathy. The patient with the lowest or the non-responder would be the narrow QRS complex, as I have explained before. That the narrower the QRS complex, it means the less dysynchrony or the less the same time usually the left and right ventricle of this patient function properly in the timing of the pumping. You put the CRT in, there's no need to resynchronize it. Okay, so I am going to after we have talk about the type of device and the indication of each type of device. So the next topic I'm going to speak is about the device system. There are patients who need to implant the device, and the second one is the pulse generator. The photo on the right is the pulse generator. It's the small device size around a small size nowadays, and we put this into the subcutaneous of the patient, and there are leads that connect between the pulse generator into the patient heart. This is the lead. And the last thing we need is the programmer. The programmer is the device that we connected with the pulse generator, and we could program this pulse generator to work properly with the patients. We can program the rate, we can program the type of the pacing, and if it is an ICD, we can program how many times you would shock the patient and how powerful with the joules you would like to give the therapy of the patients. With the system, in the middle, this is the leads of the patients. The leads inside the leads there is electrical conductor or wire, which would conduct the impulse which generate from the pulse generator into the patient heart. And there are also the insulator at the outside of the wire. Insulator is the material you wrap around the wire to prevent any further injury from outside the wire and to prevent the conduction from other electrical activity outside the system. And when you pace the patient, the pulse generator usually stimulate the small electrical current through this lead to the myocardium. This called the pacing stimuli. And also the device could also receive the sensing function. They receive the electrical from the heart and they send back to the pulse generator to analyze the intrinsic electrical of the heart. So this lead can generate the electrical and also can receive the electrical from the heart. It's called the sensing function. So the generation of the electrical called pacing function, and the receiving of the intrinsic signal called sensing function. This is the pulse generator. There are many parts of the pulse generator, which there are the header. The header is the part we use to connect to the leads. We put the leads into the channel of the pulse generator. If it is a dual chamber pacemaker, the upper channel is the atrial channel, and the lower channel is the ventricular channel. There are on the right side the dark gray in the picture. It's the battery. This battery would last around 8 to 10 years, regarding to the use time of the patient. And there are also the circuit which would lead to the pacing and sensing function of the generator. This is what the real generator looks like. And the generator would have this part. It's called the reed switch. The reed switch is when you apply the magnet onto the pacemaker. This reed switch would switch the pacemaker into a magnet function. I would explain it later in this session. What is the magnet function in the pacemaker? Every pacemaker has this reed switch. So if you put the magnet in the pacemaker, and even when the pacemaker is programmed in any type that you have programmed it before, it would switch into a magnet program. And I would like to talk about the pacemaker leads. We could implant the pacemaker leads into two positions. The first one is called the epicardium. The epicardium is outside the venous system, in the outer part of the heart. And the second one is endocardium. Endocardium is the inside the chamber, the part that inside the chamber. We put the pacemaker through the venous system into the chamber of RV or RE. This one is endocardium. But the epicardium is you have to operate the patient and put it outside surface of the heart. And there's number of electrodes on the leads. There's type of unipolar, bipolar, and tripolar. Unipolar is when you have only one electrode on the leads. And bipolar, you have two electrodes on the tip of the lead and on the lead itself. And the tripolar, we don't usually use it often in the present. And we have to have the implant chamber. So the leads for the atrial and the leads for ventricle has a different type and different anatomy of the leads. The first one I'm going to talk about is the epicardial lead. The epicardial lead is the photo on the right is the photo of the epicardial leads. It usually have a plate and a suture site, and you have a coin which would give you the attachment to the epicardial side of myocardium. This type of leads needs the suture between the leads and the epicardium of the patient. So we need the suture on this hole. The epicardium lead has a very high stimulation threshold over time, higher than the endocardium leads. So the epicardial lead is not the first choice when we would like to implant the patient with pacemaker. We have to have a contraindication for the endocardial lead pacing. Patient needs to have some special clinical setting to be put into this type of leads. And the disadvantage of the epicardial lead is that they have a a high movement between the cardiac and the leads because it is outside and the leads can be interfere with the cardiac and also interfere with the diaphragm around the near side of the implant of the leads. And also this lead could be easily break down because of the pressure of the thoracic cage outside the heart is higher than the chamber, higher than the pressure inside the heart. And this would lead to an easily conductor failure and the insulator breakdown. So now I'm going to talk about the electrode on the leads. The first one is the unipolar lead. The unipolar lead is a one coil with several stand leads with only the cathode one on the lead. And it has only one layer of insulator. This unipolar lead could only be function when you connect it with the pulse generator and the pulse generator is put inside the patient because we need another electrode, which is the pulse generator itself. So the unipolar lead is the cathode electrode, and the pulse generator is the anode. So we need both of it to conduct the pacing of the patients. The bipolar lead is different. There is two coils with several stands inside the leads and two layers of insulator. The tip of the bipolar is the cathode, and the layer outside in the leads is the anode. So this bipolar leads usually you can paste it within the lead. You don't need to use the pulse generator as the anode. I mean that you have to connect the lead to the pulse generator. That is the thing you need to do. But you can use you can generate the electrical impulse from the tip of the lead itself. The pulse generator does not need to be the anode of the system. And if the outer layer with the anode of this type of lead, if it is breakdown or some problems occur with this type, you can still use it as a unipolar. You can switch off this outer layer and turn it into unipolar by using the pulse generator as an anode. This is the picture of the both unipolar leads and the bipolar leads. And this is the tripolar lead of the pacemaker. Not the pacemaker. It's the tripolar lead of the ICD. You can see that the tip is you have tip and ring as an anode, as a cathode and anode, and the RV coil can be another electrode for you if you want to use the RV coil as another electrode. But we don't usually use this one because we have these two electrodes also, and we use the bipolar instead of the tripolar lead. So the pacemaker leads. This is the parts of the pacemaker leads. They have a connector pin, which is connect to the pulse generator via the channel that I have spoken before. There's insulator outside the leads to prevent the injury to the leads, and there is conductor or the wire inside the leads to conduct the electrical signal from the pulse generator. This conductor wire must have the tensile strength to be flexible as the cardiac cycle or the patient have movement to prevent the fracture of the conductor or the wire. We need an electrode, the anode and the cathode. The tip is cathode and the ring is the anode. And the last thing we need is how to fix the device to the myocardium of the patient. There are two types of fixation, the active fixation device and the passive fixation device. This is the connector pin. The connector pin, and this is the collar of the collar of the pacemaker. When the collar of the pacemaker is used to fix the leads. You have to suture the leads and the muscle of the patient around the pulse generator, so that the leads won't move after you have implanted in. If you don't fix this suture collar, the leads would come out and it would not be in the proper position after the implantation. And you put the connector pin into the channel of the generator. This need to be farthest inside and further than this 4 screw, because if you don't put the connector pin properly, the pacemaker function would not. The pacemaker would have problem with the pacing function. So you need to be very careful when every step you implant it. This one is also the important step, the putting the pin into the channel. The lead. This is important terms you need to know, and it is one of the indicator we use to follow up the leads after implantation. We call it the leads impedance. Impedance is similar to the resistance, but it's not equal. Impedance is the resistance of the lead plus the capacitance of the lead. We use this one. We use this impedance to follow up the patients, and if there is some change in the impedance, or it is not in the normal impedance range, there must be something, or there must be problem of the leads, either the lead fracture or the insulator break. The measure unit of the impedance is in the ohm unit, and the nominal impedance is around 300 to 1000. It depends on the manufacturer. With the different manufacturers, sometimes the normal impedance is around 200 and to 2000. The important thing is that you follow up the impedance and you see what the difference and how difference between the previous check and the current impedance you have obtained. So do you know which patient is likely to have the problem with the leads according to the impedance? A or B patient?
A.
Okay, it's easy. You see that the past 6 months ago, patient has 600 impedance, and now it's gone up high to 1000, more than 20%. So the patient A must have something with the leads. As I said before, we consider the trend more than the specific lead impedance. The trend is more important than one-time impedance. Nowadays, the pacemaker usually automatically check the impedance at the regular interval that you don't need to put the programmer in and check it yourself. The pacemaker have been programmed to automatically check the impedance, and you would have a graph of impedance over time like this. This is the graph from the pacemaker. You have a trend of the impedance over time, and you can see that if the trend is the same over the automatically check impedance, the pacemaker would not have any problem. But if the trend has changed a lot from one time to one time, you need to consider if there is something wrong with your leads. Change in the leads impedance is the most vulnerable component of the pacing system. It indicates that the system is failing, and the etiology of transvenous lead failure, the most common is from if the impedance has changed, is the insulator defect. The outside material that wrap around the wire has some defect, like they have some tear or they have some leakage. The impedance would change. Other that can cause the impedance to change is the conductor failure or fixation failure. If you have an impedance change and you check everything in the pacemaker and you don't find any specific problem, you have to bear in mind that there must be something and this is not normal. You have to follow up and some problem might come up later. I have a patient with a high impedance, and I have checked through the chest X-ray. There's nothing wrong. I have checked other function like pacing and sensing function. There's nothing wrong also. But 2 or 3 months later, it has come up that the insulator was break and some threshold of pacing is going up after that. So if there is something wrong with the lead impedance, but you cannot identify any problem, you have to follow up patients sooner than the regular follow-up. This is the, and I would like to talk about the steroid eluding lead. This is the part of the lead that would be implanted into the patient myocardium, the tip of the lead. Nowadays, we usually put the steroid into the tip of the leads to minimize the fibrous formation when you have already implanted. It is good because when you fix the lead, the tip of the lead into patient myocardium, and for a long time, there would be a fibrous cap that would come up to the leads, and when there are fibrous cap, the electrical from the leads would not going into the myocardium easily as before there is no fibrous cap. So the long-term threshold, pacing threshold would gone up, and the pacemaker needs more energy and more energy consumption to generate the pulse. So we put the steroid in to prevent this fibrous cap, and this would save a long-term energy consumption. The type of steroid that we put into the tip of the lead is the dexamethasone. Or you can put the prednisolone in, but the dexamethasone is more effective than the prednisolone. Because the prednisolone has a high affinity to the protein, and the early edema of protein-rich material after we implanted, if we implanted the myocardium, some of the cells would secrete the inflammatory substance which has a protein-rich substance, and prednisolone would attach to those protein and does not work properly, it would deactivate the prednisolone. So the dexamethasone would be more effective than the prednisolone in putting in the tip of the lead. This is the graph with the difference between the pulse width and pacing threshold between the leads without steroid and the steroid eluting leads. The black one, the CL, is the no steroid eluting lead or conventional leads, and the white circle is the steroid eluting lead. You can see that the conventional lead has a very high pacing threshold at the first time, at the early of the implantation, and after that the threshold would come down, but overall threshold is still higher than the steroid eluting lead. For the steroid eluting lead, the threshold tends to remain relatively low and flat throughout the times. So you see that if the threshold is lower, the pacing threshold is lower, the more you can save the energy of the pulse generator, and the longer patient can use this pacemaker before the battery deplete. The stimulation, the pacing threshold after implantation, usually this one is occurs in both conventional leads and steroid leads, but steroid leads tend to have lower threshold than the conventional leads. For the first week, we have the myocardium inflammation because we just screw it into the myocardium. This usually gives the rise of rapid threshold within the first 24 hours, and it will reach the peak of the high threshold of around 1 week. And after 6 to 8 weeks, the threshold would be lower and lower. And after the 3 months of implantation, the threshold would remain constant. So this is the chronic threshold where we program for the long term of the patients. After we implanted patients with pacemaker, we usually program the pacing threshold high like 3 millivolts or 4 millivolts before, and after 3 months we usually lower the program threshold to the chronic threshold of the pacemaker. As I said before, this also happened in the steroid eluting electrodes, but the steroid eluting electrodes usually demonstrate a very low acute threshold, maybe as similar as the chronic stimulation threshold, and this would give you this would save you a consumption of energy. So we come to the how we can fix the lead to the myocardium. There are 2 types of fixation: a passive fixation of the leads and the active fixation of the leads. You see the tip of the passive fixations. This type of the fixation requires a manual fixation. You have to twist the lead for it to attach to myocardium. The implanter have to twist the lead himself. The active fixation, we can use the screw. We use the screw attached to the leads at the other side of the lead, and we screw it, so it's an active fixation. The types of the fixation or active fixation leads, you can choose between these types, and the company usually claim that there's no difference between the strength of the attachment of the leads between these 2 types, but there is some type of the lead that you would like to use the passive fixation more than active fixation when you are worried about the injury when you fix the lead with the myocardium, such as when you want to do placing on the his bundle directly, you would like to be careful about the injury to the conduction system. So you choose the passive fixation that would could be control the damage to the conduction system. And the downside of the passive fixation of the lead that it has the ties. The ties could be snare up into the trabeculae. It can accidentally attach to the trabeculae of the RA and RV, and this could cause the injury to the other side of the RA or RV, which the active leads does not have the ties that could be snare into the other parts that we have to be careful about. The difference between two leads, the active fixation leads are usually easier to fix because we use the screw to fix. The passive lead, we have to twist it by ourselves, so it might be not as easy as the fixation of the active lead. The reposition of the active fixation leads is also easier because you can screw in and screw out easily. The passive fixation, if you twist it in, sometimes you cannot twist it out easily because we use our manual twist hand to twist, and we don't, the axis of the twist is not the same as before, so it's much harder than to reposition it. And the dislodgement is less common with the active lead because the screw is easy to put down, and it could be deeper in penetration of the myocardium, and also less difficult for the extraction. The con side, the good side of the passive lead is that the trauma to patient is less, the risk of cardiac perforation is also less, and the threshold is lower than the active fixation leads. And the ideal for the patients who needs a passive fixation leads is the patient with the heart failure, because in heart failure patients, some patients has very thin myocardium, and it is easier to injury or cause the cardiac perforation with the active lead in this type of patients. So passive fixation might be a better choice in patients with heart failure. Okay, for the take-home message, the first thing I need you to know is the type of pacemaker. You can differentiate what is the type of pacemaker and which type is suitable for which indication. Okay, this is the first topic in this session. Do you have anything to ask before I move on to the topic how to implant the pacemaker?ถามได้นะครับเป็นภาษาไทยก็ได้ถ้าไม่เข้าใจตรงไหน
ยังไม่มีคำถามค่ะอาจารย์
งงไหมมันค่อนข้างใหม่นะพี่เข้าใจอยู่โอเคงั้นอยากจะพักเข้าห้องน้ำอะไรสัก10 นาทีไหมเดี๋ยวจะมาต่อเรื่องimplant ยังไง
ได้ค่ะอาจารย์
โอเคงั้นเดี๋ยวเรากลับมาเจอกัน10:40นะ
โอเคค่ะ
อาจารย์คะอาจารย์คะแล้วอันท็อปิกต่อไปอาจารย์ยังจะมีแฮนด์เอาท์อยู่ไหมคะ
มีเดี๋ยวพี่ส่งให้เลยเนี่ยเดี๋ยวกำลังจะส่งให้
ได้ค่ะอาจารย์ขอบคุณค่ะ
ส่งแฮนด์เอาท์ไปในเมลน้องนะ พอดีมันส่งเข้าไปในแชทไม่ได้อีกแล้ว
ได้รับเรียบร้อยแล้วค่ะอาจารย์
พร้อมไหมครับ
พร้อมค่ะอาจารย์
โอเคได้สไลด์หมดแล้วเนาะ
ได้แล้วค่ะ
Okay. Um, okay, so I'm going to talk about how to implant the cardiac implantable electronic device step by step. You may not see the whole picture right now, but if you have a session where you could observe in the real setting, you will see what we do with this type of patients and how we deal with all the situations in the EP lab. So there are important three parts of this talk. The first one is the pre-operative preparation for the implantations. This is important to prepare the patients before the implantation. The second one is the basic cardiac implantable device implant technique. And the third part is the complication after the implantations. You might not be the one who implanted, but you need to know which procedure and step by step what the doctor do because you have to help him with all the techniques he has to perform. The first one, the part this part is as important as the technique of the implantations. Is the pre-procedure the preparation of the patient. Because if you not prepare the patients well, this would lead to problem in intraoperative and also after the implantations. The patient needs to be consent before the procedure. The blood test we have to done. The important one is the clotting factor and the full blood count to see if the the platelet levels of the patients and how the clotting factor is. If there is some tendency to bleed in the patients, we may need to correct before the implantations because this might lead to excessive bleeding during the operations and also this might lead to the pocket hematoma after the implantations. And the third one is the renal function. This might not be as important as the clotting function or the blood count. But if the patient has the end-stage renal disease or the chronic kidney disease, this is one of the important factors that would lead to the infection of the pocket and the infection of the pacemaker system. Another one that we have to consider before the operation is the medication patients take. The warfarin, the anticoagulant, we need to keep the level of INR less than 3.0 from the bruise control trial, because if the INR is higher than the 3.0 level, this would lead to pocket hematoma and the pocket hematoma might lead to the infection of the device. The aspirin and clopidogrel, the antiplatelet, is no need to be stopped before the procedure. This one is but if you go out to the real setting, some doctors still prefer to stop aspirin and clopidogrel before the implantation because they think that they have experienced some problem after the implantation with the patient still ongoing or still taking the aspirin and clopidogrel. And the last one, the NOAC, the novel anticoagulant, 4 types of it, the dabigatran, edoxaban, rivaroxaban, and apixaban. We need to stop it 2 days before the implantations. But some new studies or newer guidelines only stop it for 1 day before the implantation. We need, before the implantation, we need the antiseptic skin preparation. We need to prep the skin with chlorhexidine and you have to bath and shampoo daily for 5 days before the elective procedure. You have to shave the area around the implantation. You don't want any hair area, or you don't to interfere you with the site of implantation. NPO is prohibit patient to eat anything at least 6 hours before the operation. You establish the IV line on the arm on the site of implantation. This is you have to put it on the side of implantation because you will use this IV to inject the contrast into the venous system, so you can puncture the venous easily. And the last one, this is the important one also, the IV antibiotics 1 hour before the implantation. This would lessen the pocket infection and the system infection after implantation. This part is important. You have to do it in every patient before the implantation of the cardiac implantable electronic device. And this is the room where we perform the implantation. It's the Electrophysiology Lab. We need a fluoroscopy of the C-arm. We need a monitor to see the patient hemodynamic, and also to see the X-ray of the patient. We also need the defibrillator. This have to be prepared, because if you perform any procedure inside the patient's cardiac, the unlawful event could be happen anytime. Patient could experience cardiac arrest, VT or VF. We will need this to be ready to do the CPR. And this is the sterile room, like the operative room. And another important thing is that we need the programmer and the representative of the device to help us guide the implantation. There are two sides of implantation. As we have spoken in the last session, there's two types: the endocardium or transvenous implantations, and the epicardial implantation, which would use the epicardial lead. The difference between two of these is that the epicardium needs to be operated. The patient needs to be cut in the midline or the subxiphoid to put the pacemaker into the epicardium side of myocardium. This is we call a bigger operation than the left one. The left one is a small operation. We can do it under the local anesthetic. When the patient deliver in the room, we check all the vital signs. We put all the equipment ready. The next thing we do is to sedate the patients, because even it's the small operation, the patient could experience a lot of pain. We have to sedate the patient with the sedative drug like midazolam, fentanyl, or propofol. And during the sedation, we have to monitor the airway and monitor all of the hemodynamic patient have. We have to clean and drape the site of the implantation if not done before, and we have to prep it again with iodine, alcohol, or chlorhexidine. The site of implantation usually on the left or right chest wall, and I will talk about it in details in this session later. This is the site of implantation. Usually we implant it on the chest wall, around under the clavicle, around the deltopectoral area. after we have shaped and we have cleaned this area, we will inject it with the local anesthetic drug such as lidocaine. And after we injected with local anesthetic drug, we would open the pocket. We would we would make the incision around this area with a small size around 3 centimeters or 4 centimeters according to the device we would put into the patient. There are many types of incision you can make. The transverse incision or the horizontal one, or you can make a lot of different type of incision according to the patient preference, because some patients might concern about the scar, and maybe according to the operator preference, some doctors like to do some type of incision and some might not like the same type. This is not serious. You can see the doctors perform different type of incision depending on the operator. But the common approach is the parallel to the deltopectoral groove, with one finger medial to the groove. You can see in the picture we have to identify the groove by touching the patient's that area, because this groove you can allow to access the vein easily. You can access cephalic vein, axillary or subclavian veins also. And when we have identified this groove and we have confirmed the site of implantation, we would make the incision. The next step is to access the venous axis. The venous axis is the first route to lead the lead into the ventricle or to the atrium of the heart. There are 3 veins that could be accessed: the axillary vein, the subclavian vein, and the cephalic vein. These three veins have a pro and different pros and cons, and different technique in doing the access. The first one, the axillary vein puncture, and this is the most common site that we usually do, and this is the best site to prevent other complications. The axillary vein is the vein that connects around the axillary area, around the first ribs and the third ribs, and this vein would lead into the superior vena cava, and it's not as near as the subclavian vein to the subclavian bone. So this vein would not lead to what we call the subclavian crush. It's the crush between the subclavian bones and the leads, and this would lead to the lead fracture. To prevent that event, we would do the access to the axillary vein. When we use the fluoroscopic anatomic guide to puncture the vein, or we can inject the contrast via the IV access, and we would see the vein in the fluid, and we would puncture it. Or we can also use the ultrasound to identify the veins before the puncture of the vein. And if we could puncture it, after that we will put the long wire into the vein, pass the IVC into the chamber. This is I described it earlier, the subclavian crush syndrome. It's the crush between the leads and the subclavian bones. The risk is medial subclavian puncture. If you puncture the subclavian vein, this has more chance to occur than puncturing the axillary vein or the cephalic vein. So we prefer using axillary vein first as the access site of the implantation. If the crush happened, the lead would fracture, and this would cause the system failure. This would not happen as soon as the implantation has done. It will happen later after the implantation, when the patient has used his subclavian bones and his arm repeatedly crushed into the leads. This is the picture of the venogram I talk about. We injected the contrast in the IV line that we established at the same site of the pacemaker we would like to implant. We inject the contrast in, and we would see that this is the axillary vein, and this could guide us to puncture. Another venous exercise is cephalic vein. Cephalic vein could not be punctured with the needle as the axillary vein because it is very small. So we need to do the cut down operation. We need to operate a small surgical area, and we have to find the cephalic vein and put the wire in it. This is the cephalic vein that we could find by the small surgical operation we call cut down. This is relatively safer than the puncture in the aspect of pneumothorax. You know, the perforation of the lung, because when you put the needle into the axillary vein, there is some chance that you might puncture into the lungs, and that would cause pneumothorax. If you do the cephalic vein, this has no chance to cause pneumothorax because we didn't puncture into the lungs area. We just do some surgical procedure around the muscular side. It does not went deep into the thoracic cage. So the size of implantation. This is when we have already made the incision, we would have to create the pocket for the generator to be put into the subcutaneous of the patient. We made the incision. We have to cut it down deep into the pre-pectoral area, and we have to create the pocket the same size as the generator. This is the photo we create the pocket. And after we have access, we put the wire in, we have the pocket ready. We would put the leads in. The important thing before we putting the lead in is that the leads must have the stylet inside the leads to guide it to the place where we would like to attach it into the myocardium. If we don't put the stylet in the leads, it would not be easy to control the leads to the site where we want to implant, and we cannot fix the lead with the screw into myocardium without the stylet. So before we put the leads in, we need to prepare the stylet. We have to create the stylet into the shape that we want, because the shape will help us guide to the position we like to implant. So we have to manipulate the stylet before. And after we're done with preparing the stylet, we will put the stylet inside of the leads. for the right ventricular leads, we have to, after we put the stylet in and we put whole lead and stylet into the heart, we have to advance this lead into the RA first and advance it into the RV. The first one is to advance into the inferior 1/3 of the RA. And after that, we advance the stylet into the distal end. And the third procedure is we insert the pre-shaped guide wire that we have already prepared before into the leads. And then we advance the lead across the tricuspid valve. And we manipulate the leads into the site that we want to attach it. It could be right ventricular apex, or it could be right ventricular septum. You could prefer, you could do it both as the operator preference and as the condition of the patient is preferred. And after that, we fix the lead to the myocardium and we withdraw the wire. This is the real fluoroscopic picture of the implantation. And after we have fixed the leads to the RV myocardium, we remove the curved stylet that we have prepared before, and we put the straight stylet into the leads. And we manipulate the leads into the shape that we like to leave it after the implantation. And then we put the stylet back. And we test for the stability by pulling the stylet and some gentle pull to the leads. And this is finished with the lead implantation inside the cardiac. This is the fluoroscopy about the position of the leads. The first one is the RV apex. The second one is the lower septum of the RV. And the third one is higher septum almost onto the RV outflow tract. We could implant it all of these positions according to the clinical setting of the patient and the preference of the operator. This is not so much difference in the technique. Okay, so that is the pacemaker leads. We just put it in the RV or the RV apex or the RV septum. But there's some slight difference in the AICD leads with the defibrillator. You see that we need the coin of the. We also not only the pacing side that have to be accurate in the position, but also the coil of the leads have to be in the proper position in case we can use it to give the therapy to the patient. The AICD coins, usually we prefer to put it into the RV apex because we need the vector of shocking to be covered in the whole heart. You see that the shocking vector would be from the pulse generator to the distal coil. If we put in the apex, it would cover the whole heart. But if we move this RV ICD leads into higher septum, it would not cover some part of the heart like the apex. So in the ICD RV lead, we prefer implanted it in the RV apex. As we are implanted the leads and we screw it in the myocardium, if you see in the programmer during the implantation, you will see that there is some current injury. The elevation of the ST segment in the intracardiac electrogram. This is the elevation. If you see this injury, it means that you have already put the leads into the myocardium. The elevation is one of the indicator that tells you that the leads are attached to the myocardium. This is a good indicator. But if you see the inverted or ST depression, this should give you cautious that the lead might be put too deep, and this might mean that there is some perforation of the cardiac. If you see this signal, you should tell the operator as soon as possible for him to withdraw the leads out and place into other position. If you did not aware of this, it would lead to cardiac tamponade, and maybe the patient would have some unstable hemodynamic. This is important one. Okay, that's finished with the right ventricle leads. So we come to the how to put the right atrium leads. As I have spoken in the last session that the RA leads and RV leads is different. The RA leads needs a J-shaped lead to attach into the right atrium appendage. If you don't have a J-shaped lead, the RA lead could not be attached to any part of the atrium. The first procedure to be done is to put the RA leads into 1/3 of the right atrium using the straight stylet leads first. Then we remove the straight stylet leads, and we used the J-shaped configure lead put it into the RA leads. The tip of the RA leads would come up as the J-shaped curve, and after that we pull back the RA lead into the right atrium appendage position, and we fix the lead at this position. This is the view, the PA view of the RA lead attached into the right atrium appendage. The position we like to is the right atrium appendage. And this is the lateral view of the RA lead. This is the real X-ray of the patient. The first one is AP view, and the second one is the lateral view. You can see that the RA lead is in the J-shaped curve. After we have implanted all the leads into the cardiac, we have to move to secure the leads in the muscle layer in the pocket. This is also important because it's a tie stay suture to the muscle layer. This is important because this would prevent the move of the leads after implantation while patient have some activities with his arm. If you don't suture this well, the leads might dislodge or might come out of the proper position, and this lead to conduction failure. The first tie, you tie the suture to the muscle layer before tying to the leads. And you remove the stylet first before you tying the leads. And before you tie hard to the leads, you have to attach, you have to adjust the slack of the leads inside the heart with using the fluoroscopic guide. And after you have adjust the slack, you have removed the tie, you could secure the lead with a permanent tie. You have to do this for 2 or 3 times per lead before finish with the implantation. The picture below is when you fix the lead with the muscle inside the pocket. And after this procedure, you would, after you have already fixed the lead inside the myocardium, you have adjust the slack, you remove the stylet, and you fix the lead with the pocket. After that, you connect the generator with the leads, and you put the generator in the pocket, and you suture up the pocket. That's the complete procedure of the implantation. So there's some slight difference when you are implant the CRT device. As you know before, CRT device has 3 leads. The RA and RV leads is implanted as the same as pacemaker and ICD as mentioned before. But the third leads into the LV have to implant. They have a different technique in implantation. We have to cannulate the vein of coronary sinus and put the leads through the coronary sinus into the LV epicardium. So we need to cannulate the coronary sinus vein. We have to inject coronary sinus angiogram, and we have to insert the LV lead into it with a different technique and different device. And after we have put the leads into the coronary sinus and LV epicardium, we have to adjust the slack of the leads and suture up the leads to the muscle in the pocket as same as the RA and RV leads, and connect it to the CRT device. This is the coronary sinus I talked about. Coronary sinus is the structure opening in the right atrium and leads into the LV epicardium. I will point it to you. This is the opening of the coronary sinus we use to cannulate. And this is the left photo is the vein here. Is connect with the opening of the coronary sinus and leads to the LV epicardium. So we can use this site to perform the LV leads of CRT. So cannulating the opening of coronary sinus is not as easy as putting the RA and RV leads. We need a special guiding sheet to approach the CS. We have different type of guiding sheets. We can choose to use the different guide in different patients for according to the anatomies of the patients. There are a lot of curve, and there are sheets that we use when we implanted the pocket in the right side of the patient. When we put the guide into the patients and we cannulate the coronary sinus, we can confirm the branch of coronary sinus by doing a coronary sinus angiogram. This is a coronary sinus angiogram, and we could see that there are many branches of the venous systems. And if we have already seen which branch we would use to put the LV lead in, we would choose from the coronary angiogram. And after we have done the angiogram and we have chosen the branch, we would put the LV leads in. This is the fluoroscopic picture of the LV leads that were put it in the coronary sinus branch. So which branch is the optimum leads position? The keyword in this position is the lateral. The more lateral, the more good of the side, and the more posterior is the better side. So the optimum LV position is lateral vein, which could be posterolateral vein, anterolateral vein, or posterior through the middle cardiac vein, but the best one is the posterolateral vein. The non-optimum LV pacing side is the side that is not far lateral and is not posterior. The non-optimal LV pacing side is the great cardiac vein, middle cardiac vein, and LV apex. I'd like you to remember the posterolateral vein is the best one. This is the one that we usually pick first. But if we fail to pick this one, we would have the alternative into the anterolateral vein or the posterior through the middle cardiac vein. There are other indicators that could be used to identify the best size of the pacing LV. Anatomical is the one thing, the lateral vein that we have mentioned earlier. The fluoroscopic can be used to guide the LV and LV tip as far apart as possible, because we want the LV and LV to be paced together with synchronization. So LV and LV have to be as far as possible to obtain the most myocardium part of both sides of ventricular and paced together. We can use the LV electrogram to identify the good side. Also, we can use hemodynamic or the ECG guide. We have what we call the dP minus dt, the pulse pressure of the hemodynamic. Or maybe we can try pacing and see what the EKG looks like during the implantation. If the QRS is narrowing in the position you put the LV in, this might be good. This slide, I just want you to know that there are many techniques that we can use to identify the best pacing side of LV. You don't have to remember it all. It might be too hard, and it might not be used in your clinical practice. There are some patients that there are some doctors that would irrigate the pocket before the closure of the pocket and before the implantation, before you putting the pulse generator into the pocket of the patient. Those doctors use antibiotics or the povidone iodine to irrigate the pocket before you suture up the pocket. But there is no positive or no clinical significance in the studies that tells you that the irrigation of pocket would prevent further infection of the pocket. But some of the doctors still performing it. You can use a lot of antibiotics and maybe you can only use the povidone and Eluding. There's no standard regimen for this irrigation procedure. And after you have implanted the lead, you have fixed the lead with patient muscle. Now you come to the point that you would connect the leads into the pulse generator. The connector into the channel of A and V. Before the connection of the generator and the leads, you have to identify that the atrial leads would go into the A channel. The ventricular leads would go to the V channel. This is very important because if you switch the channel, if you put the V lead into A channel, you put the A lead into V channel, this would cause the problem with the pacing. It would cause the header switch because the A leads, because the switch of two leads, this would lead to pacing failure in some patients. This is important. If you are implanting the device with the doctors, you have to identify the leads by reading the serial number on the leads. Or maybe you can ask the doctor to read the serial number before you connect it into the channel. And another important thing is that you have to put the lead into the whole channel as far as possible. You should not leave the space in the channel, because if there is some space in the channel, that means the connector might be loose or might not be locked in the position properly, and this would cause the loss of the connector. And also there might be some air in the channel, and this air could cause the noise in the generator. This is another important step. You should not leave any space in the pocket. You have to put the lead all into the channel. And after you put the lead in, you have to screw the leads. You can see this plug. You should have plugged in and screw the leads. There would be some tools to screw the leads before you finish with these steps. So after you connect the leads into the pulse generator, you put the pacemaker in the pocket, and you suture close the pocket. This is a suture we have to do to close the pocket. And for the final, after we closure all, we have complete implanted, we have to take a final fluoroscopic run to see. It is a good practice to do it, because you have to look for the lead dislodgement, position of the coil if it is the ICD, the kink of the leads. You have to see all the position and you document it for the follow-up. If there is some different from the final fluoroscopic after implantation, when you are at the clinic and you are follow up the patient, you have to suspect that there might be some problem with the system. And you have closed all the pocket. And after the implantation, the wound care is also important procedure. Preventing the hematoma, preventing the infection of the wound, preventing the dehiscence of the wound is also important. And this is the final chest X-ray after the implantation. You have to do the chest X-ray after implantation to see the leads, and if it is proper in the place, and to see is there any complications after the implantation, such as pneumothorax, if we puncture the axillary vein or the subclavian vein. So all of this is the endocardial implantation through the venous systems. The second type that we have mentioned before is epicardial implantations. As I mentioned earlier, this requires surgical approach of midline sternal subxiphoid or lateral thoracostomy. The indication of epicardial implantation is the children who is very small and have a low weight. A limited vascular access, you cannot access the venous side, you cannot implant it transvenously. So you have to implant it in the epicardial side. And the severe tricuspid regurgitation, because you have to implant the RV leads through the tricuspid valve. If the RV leads tear or injure the tricuspid valve, it would cause the severe tricuspid regurgitation, and this can be the contraindication of transvenous endocardial implantation. The children have to be implanted with epicardial because the children are growing up, and if you implant the transvenous leads into the children, when the children are growing up, the leads is not growing up with their bodies, and this would cause the fracture or the failure of the leads if the patient is taller and growing up. This is a picture of epicardial implantation. You can see that the leads is outside the heart. It's in the epicardial side and connect to the generator, which the pocket is in the abdominal wall of the patient. This is quite different than the endocardial leads. After we complete all the implantation, there are some complications that you need to know. They're divided into two types of complications. The first one is early complications, less than 30 days, and the second one is late complications, more than 30 days. The early complications, the important one is pneumothorax and myocardial perforation. This type of complication, you would know it in a matter of hours to days after the complications. And other acute complication is the failure to pace or failure to sense. This could occur immediately if the position of the implantation is not properly, or it is displaced from the first position you implant. So to prevent this failure to pace or failure to sense, after the implantation, 1 day after the implantation, we need to check all the function, all the sensing threshold, or the pacing threshold, and the impedance of the pacemaker after the implantation. Other less complication is the hemorrhage, the pocket hematoma, the air embolism, the venous thrombosis, or the brachial plexus injury. Other in the white letter is less complication that can occur in the 30 days. For the late complications, more than 30 days, the most common complication is lead displacements, lead fracture, and insulator breaks. The late complications are almost dealing with the failure of the system. There are less chance that the myocardial perforations or other complications that occur in the acute complication occur after 30 days. Patient would not survive if they have experienced a perforation for such a long time. And in the white letters, there are some interesting complications such as inappropriate pacemaker inhibition, pacemaker tachycardia, pacemaker syndrome. This caused by the inappropriate program of the pacemaker. We could count it as a late complication. And also the muscle stimulation or muscle switching. This is when there are many types of muscle switching. There are pectoral muscle switching, the pectoral muscle in your chest wall, and there are diaphragmatic twisting. Diaphragmatic twisting is more common. It's because the leads of pacemaker is very near very close to the diaphragm, and when we pace with the power of electrical pacing, it also paces the diaphragm, and it causes the diaphragm twisting. Patient would feel twist in their stomach and lower chest wall. This is the chest X-ray of pneumothorax. The black arrow indicates the lung that collapsed. This is the lung. And the space here is the air of pneumothorax. Occur acute after the procedure. And this is the rare complication of the late complication. It's called the stenosis of the vein. The subclavian vein stenosis, after you put a lot of leads in this patient because there's some lead dislodgement and you need to put the new lead in without extracting the old leads. And when there are a lot of leads in the veins stenosis, the vein is obstructed and it's causing the distant vein in the chest wall and also swelling of left arm. This is a rare complication, but it could be, we could experience it sometimes. The subclavian vein thrombosis. It is unusual occurs. Some settings maybe occurs in temporarily pacing while for using for more than 1 week, or there is some infections around that area. The manifestation is the swelling of the arm and the superficial dilatation of the veins. So how to cure this patient? We have to remove all the leads out, and sometimes it gets better, but some patient we remove the lead out, but the subclavian vein is still thrombosed. We have to put the stent in the subclavian vein to give the space for the blood to drain into the to the heart. So this is all the implantation procedure step by step and the technique. This is the take-home message I would like to give you, and I talked to you about this topic. You may not remember it all now, but if you have been in this field and you see the procedure, you will remember it as the time goes by. And I don't need you to perform it or to remember all the technique I have taught today, but if you know what the surgeon or what the cardiologist do in the EP lab, it would make you are smarter and you have the advantage to help them and to help the patient. So thank you. So this is finished for this session too. Do you have any question to ask me? Please feel free to do that, either in English or in Thai. มีใครจะถามอะไรไหมครับ มีใครสงสัยอะไรไหมเอ่ย
ยังไม่มีค่ะอาจารย์
ได้ครับ งั้นก็อันนี้เป็นเซสชั่นตอนเช้านะ เดี๋ยวเลิกก่อนเวลาแป๊บหนึ่ง เดี๋ยวตอนบ่ายเนี่ยมาต่อกัน2เรื่องนะครับ จะลงลึกเกี่ยวกับPacemaker แล้วก็ลงลึกเกี่ยวกับโปรแกรมของ ICD กับ CRT นะครับ ถ้ามีใครมีอะไรสงสัยจะถามก็ถามได้เลยตั้งแต่ตอนนี้นะ หรือว่าจะส่งอีเมลมาถามผมก็ได้ เดี๋ยวตอนจบผมจะให้อีเมลไปนะครับ โอเคไหมเอ่ย
โอเคค่ะโอเคค่ะอาจารย์
ครับงั้นเดี๋ยวบ่ายโมงเจอกันนะครับ
ขอบคุณค่ะ
ขอบคุณค่ะ
ขอบคุณค่ะ